who really I applaud their efforts in performance measurement. We had to start somewhere, and we started with measures that were less than perfect, but it's moved us all. And data's a drug, and we're addicted to it. We can't get enough data, and we want meaningful, actionable data. So we partnered with CMS and started to show them how the current data sets they have don't get them the answer they want, and we're showing them more meaningful data sets. And where we need help is how do we actually expand this infrastructure beyond 500 hospitals into 4,000 hospitals? How do we link this beyond surgery into surgery and primary care across the patient continuum? So it isn't about how well I took someone's colon cancer out, but it's more about how well the 18 months of critical cancer care drove the best outcome for that quality. And we're closer today than we ever were, but there's a lot of things that we need to do, some infrastructure components we need to build upon, and build the business models into it so everyone is aligned and we all have shared incentives. We're very excited about going forward, and we actually are looking forward to taking that next step.
Upstream. Just like I don't think there's a single payment solution across all specialties because there's unique differences in the question about quality. The issue for primary care is often about treatment of chronic illness, and the payback time to have good outcomes might be 5, 10, 15 years. You know, my good diabetic management of my patient today is to avoid them being on dialysis 10 years from now. And so instead, these quality measures use proxy short-term measures. You know, what's your blood sugar control? Have you had your feet checked, your diabetic eye examination? So we end up using these proxy measures that aren't truly outcome measures because the timeline is too long. And then you get into a debate about are the proxy measures the right measures. And so that's what, to Dr. Hogan's point about developing good measures, we want to make sure that those are valid measures that reflect reality. They're the things we should be measuring and should be working to improve to get those eventual outcomes.
Go ahead, John.
That's for Maria.
Okay, Graham. Second. I don't know what your microphone's on, Graham.
Is that better?
Yeah.
Okay, great. Yeah, the light doesn't reflect. I was you were talking about obviously quality and outcomes, and one of the things in the Affordable Care Act is moving to this value-based modifier system. And so, I mean, when you look at what, you know, some of the estimates are on Medicare wastes $120 billion per year due to unnecessary tests and procedures. So I mean, haven't we proven that we can deliver better care at lower costs? And now it's just about figuring out how to implement that system so that people are, as you were saying, incentivized to do the right thing as opposed to the...
Yeah, I can jump in on this if I might. This is a good first step. I mean, clearly, you know, the concepts are in there. What we've got to now do is look at the methodology. Be sure that the methodology is appropriate for what we want to get accomplished, and it gets us to a good place. But I do think it is a good first step. We're in the process of reviewing all that. It just came out in the new rule. So I think, you know, we'll be getting back to you all on that. But I do believe it is a good first step.
Let me make a couple comments, Senator Cantwell, about this, and that is about the value-based. I personally am very worried about the way it is structured. It plans to use PQRS measures, some prevention measures, and as well as look at cost that is regional. And I have to tell you that what people have said today is you need meaningful, credible data in order to do any adjustment for what the outcome or what the cost should be. I lived in Seattle. When I moved to Detroit, and I looked at patients with heart failure, I had never seen a population like this before. They would never get adjusted for adequately with administrative data. You've got a population in which 25% of people graduate from high school. They're working just to stay alive. You have people that have burned out their kidneys for long-standing hypertension when they're age 30, 35 years old. I never saw that in Seattle. They both have heart failure, but they are very different people, very different kinds of people. And so taking crude measures to try to adjust severity and adjust payments would be a huge mistake in my mind. And so the value, if you will, of some of these specialty things is that people literally spend many hours trying to figure out what is going to be legitimate here when you do risk adjustment and what is not. And they are the experts. They understand the disease. And you have to be very careful. The other thing that the cardiologists have been using is appropriate use criteria. What these are a panel gets together, including panel of payers and physicians and other experts, and they look at a lot of conditions for which we really don't have solid guidelines for. It's just that the science isn't there. And they say, this seems to be reasonable, knowing what we know. This is not so reasonable. A year ago, we started providing feedback to the hospitals on the use of stenting. And there were a proportion of cases in which they were considered to be unnecessary or inappropriate. Now, we never expect that number to be zero because there are individual differences and so on, but you ought to be pretty close to what the national benchmarks are for these numbers. And so we have seen, since we've started producing this, a decline in that number. And in fact, if you look, there's been a decline in stenting procedures the last year or 2 years in the U.S., and it's predicted to go further. So providing credible data, giving it back to those docs, will change the way in which they behave.
I certainly believe in credible data, and I don't know, Mr. String, if you want to, Dr. String, weigh in on this. I don't, I mean, when I think of Spokane, I think it's a great place, and I certainly think that the population with its city title of near nature, near perfect is a good symbolism, but I don't know that we're talking about healthier populations here, or we're talking about healthier practices. And I certainly think we have healthier practices in the Northwest rewarding things that have driven down costs and produced better outcomes. And frankly, people in our region are very frustrated that we deliver care that way and get less reimbursement, and less people want to go practice there, and somebody can go practice somewhere else where they can run up the bill to the American taxpayer. And my constituents don't be happy with good data, but just to assume that they're healthier and that someplace else is sicker and we should just pay more is not going to work. And so I'm glad we're moving down the track, and I guess we're just going to have to focus on what good data is. And on that, so if you have any comment on that, Dr. Stream, and also on what we need to do to encourage graduate medical education. If we're looking at the numbers that we're looking at to get medical homes and primary care, we have a big gap right now in encouraging primary care physicians. And what do we need to do for graduate medical education to really get that workforce plugged in?
So several questions in there. Certainly we need good data about all of these things, care practices, but populations do differ somewhat. Inner city populations with more poverty, less education, those social determinants of health have a huge impact on the health of our public. So we need good data about both, so that if we're making risk adjustments, that they're true and accurate. I can speak to value-based purchasing as not necessarily a program, but as a concept that applies to primary care, and we absolutely have to build a stronger primary care foundation if we're going to have any success improving the quality and cost effectiveness of our healthcare system. And that really is this blended payment model that supports the patient-centered medical home model, decreasing over time in importance of fee-for-service, having a meaningful care management fee that does this care coordination, prevention, and wellness. And then the piece that gets to your question is that shared savings piece, or if it's pay for performance, could include both quality measures and appropriate use, efficiency sort of criteria. But that would be that third leg of the stool about payment to support primary care. But you're also right, and I appreciate you teeing it up about the workforce issue, and I would emphasize that decisions made that influence specialty payment have a huge influence on specialty selection of our medical students, and currently a strong disincentive to people to choose primary care, and we have to narrow that income gap between primary care physicians and median subspecialty income to have the impact we want.
But just for what everybody's been talking about, do we have the workforce now to implement the strategy that we're talking about?
Absolutely not.
All right. So, okay. So thank you.
If I could follow up on that, Senator, the whole issue of medical school education, graduate medical education, we at the AMA have been looking at this very critically, and this is a problem which preceded current issues surrounding payment and delivery. This isn't new. Looking at spots for graduate medical education, changing the curriculum in medical schools, making sure that primary care is being taught and rendered in places not necessarily traditional for primary care education, that we're opening and expanding the venues in which we can do the education. So all of these things are on the table as we talk about it. It takes 7 to 10 years to grow a doctor. And we've got to get those slots filled out. We've got to have more funding towards that as well. And it's one of the imperatives that's part of this whole discussion.
Thank you.
Mr. Chairman, thank you very much. When I first started law school, one of the things that was impressed upon me was the difference between a profession and a business. And it was all about the individual client. You had to give your absolute commitment to that client, whether the client could pay or not, and regardless of their idiosyncrasies and so on. And I began to practice insurance defense work and found that it was true in spades of the medical profession. Data is collected to provide information about averages, but every patient is an individual, and I know that all of you are committed to treating every one of your patients as an individual. The rub comes when you're treating patients that are paid for by the United States government under a set formula of one kind or another. And my question to you is, in devising, and we recognize that the formulas, the pay scales, however they're going to become embedded in a replacement for SGR, will need to be developed by the professions themselves to take into account individualized circumstances, including regional circumstances in the country, as Senator Cantwell was just pointing out. But my question is sufficient attention being given to the requirement that the care really be patient-centered? When the patient walks in the door, I have one obligation and one obligation only, to take care of that patient to the best of my professional ability. At the end of the day, I got to get paid, but not to have the payment drive the care. And then a second sort of related question is, when we deal with this, because of our unique budget requirements here in the Congress, we have to set a 10-year plan out. And it's very hard for us to know whether the 8th, the 9th, and 10th year are going to work with what you're recommending for us in year 1, 2, and 3, and so on. And just for our own purpose, I wonder if you have any suggestions for us, and if you want to think about this and get the information to the chairman later, how we would devise something that we think is going to work over a shorter period of time, but we really don't know over a longer period of time. That was one of the problems with SGR to begin with. Thank you.
Anybody? Mr. Chairman, thank you, and Senator Kyle, thank you for the question. Two responses to this, in my mind. Where we've begun with performance measurement and valuing services is still in the silos of care. It sits in the various different performance programs, and it's not as patient-centric as it could be. And as we start to spread performance measurement across bundles and ACOs, and we look at population-based performance, how well we're taking care in a continuum, and we start sharing the attribution, it becomes more patient-centric. So where we were 3 or 4 years ago, when we started really pushing hard on physician performance measurement, was just at the beginning. How do we begin to measure individual physicians and reward them, a hospital and reward them? We've grown over the last couple of years to start to understand some of the points made by my colleagues at this table, and from input from all stakeholders, from the purchaser groups, from the private payers, from patients, who are helping us look at this and say, well, this is a better measure because it really is more meaningful to the patient. And as we move to that, it doesn't necessarily fit within the payment structures or silos of payment. So we have to look at alternative payments, which is to my second point. And that's where we propose replacing the SGR with the value-based update, which says, let's pick a target. We want to improve cardiac care this way. And it's not just the cardiologist. It's the primary care, the cardiologist, it's the cardiac surgeons, it's anesthesia, it's pulmonary. Everyone who touches that patient will be involved in incentives that's the target we want to get to. And let's strive for that target. So I think we're becoming more patient-centered. We're not quite there yet, but we think replacing the SGR with something that actually is patient-driven targets. Does it get to 8 to 10 years? I hope so. But it may take us 8 to 10 years to even get to that point. Will it be something else 12 years from now? We're always evolving this. So I'm not going to say this is forever.
That's a fascinating question. Anyone want to respond to that? Yes.
Well, I'd like to respond to the patient-centered part. And I agree completely. When a physician is in an examination room with a patient, their best interest should be the highest priority. Making sure that patient gets the treatment that they need that will improve their health, improve their quality of life. But what we're finding, and it goes to Senator Cantwell's comment, is we know that our system currently provides care that people don't benefit from. And my responsibility as someone's physician is to make sure they get the care that they need, but they don't get care that doesn't enhance their health. And that's where I think, and it doesn't give an easy solution to the SGR problem, but it is a potential for cost saving to eliminate care that does not contribute to people's health. And that's an area where Dr. Weaver was mentioning stenting data, and the power of that information is physicians want to get A+ in their scores, and so when they're comparing to one another, that's another aspect of professionalism is excellence in the profession. So we need that going forward.
Doctor?
Thank you, Senator. Senator Kyle, I think one of the answers to your question about why is the care not as patient-centric as it could be is in the silos of payment, that we pay by area of the country, so that areas such as our area in the West, Mexico and Arizona, have lower payment rates for the same service. There's differentials in the site of service, the same service in a different setting. A hospital, physician office is paid far differently. If we had the payment more follow the patient, that would do a lot to go patient-centric in terms of how we focus on that care. And I think breaking down some of those silos so that the money can follow where the patient is best treated will allow us to move patients from more expensive sites of service to less expensive sites of service and make that a very valuable part for healthcare. I'm also very concerned about the whole workforce issue. ASCO, American Society of Clinical Oncology, did a study some years ago looking at the number of oncologists that we are currently producing versus the number that we're going to need in the next decade. And about a third of cancer patients may never be able to see an oncologist because there simply aren't enough of us. So we are working hard on trying to create new teamwork methods of care so that we can get the expertise we need out to those patients, put them in the right side of service. I think the most expensive drug we give someone is one that doesn't work. We're hoping that with personalized medicine and with very good techniques of figuring out what will work on a given patient's cancer, that we'll be able to avoid a lot of those unnecessary processes that you're talking about. Doctors are really interested in doing that. It doesn't benefit us at all to go to a patient and say, I'm sorry, this didn't help.
Perhaps.
In my earlier life, I was a medical liability defense lawyer, defending doctors, hospitals, nurses, healthcare organizations.